Hello, my name is Claudio Sandroni from Gemelli University Hospital in Rome, Italy. During the next 10 minutes I show you why multimodal prognostication after cardiac arrest is important. About 80% of patients who are resuscitated from cardiac arrest are comatose. Their prognosis is uncertain and it's often poor. These are data from the Italian multicenter prognostication study PRONICA. They show that among 445 patients admitted to ICU in a coma after cardiac arrest, 60% were dead at 6 months, and a half of those who survived were vegetative or were severely disabled. Death after cardiac arrest is mainly neurological. These two studies were conducted by two different groups, in different times and places. The results are very similar, and show that over 2/3 of deaths occurring after resuscitation from cardiac arrest were due to neurological injury. They are depicted in blue in the pie chart. But if we delve more into this data, we see that only a minority of these neurological deaths were brain deaths, so due directly to hypoxic ischemic brain injury. The majority of neurological deaths, and also the majority of the total deaths, occurred after withdrawal or life-sustaining treatment because of an expected poor neurological outcome. So, in order to avoid an inappropriate withdrawal of life-sustaining treatment in patients who still have a chance of neurological recovery, we should minimize the risk of a falsely pessimistic prediction, and so the false positive rates of the predictors we use. On this topic, the expectations are very high. This recent survey explored among healthcare providers what were the preferred characteristics of a prognostic test after cardiac arrest. There were more than 600 respondents throughout the world, mainly physicians and mainly in North America. The results showed that for the majority of respondents, the highest acceptable error rate of a test predicting poor neurological outcome was 0.1% or less, 1 in 1,000. I can tell you that this expectation is unrealistic. To achieve this goal, we would need not only a predictor with a 0% false positive rate, but the upper limit on the 95% confidence intervals should be within 0.1%. At present, none of the predictors we use fulfills these requirements. But there's a second reason why this expectation is unrealistic. For many predictors, pursuing a 0% false positive rate will not be feasible, nor desirable. This is the case for predictors whose results are reported as continuous data, like biomarkers. For instance, neuron-specific enolase or NSE. NSE is the most extensively studied biomarker of anoxic brain injury and the only currently used in clinical practice. Results of NSE are reported as blood levels, and therefore as a continuum, but in order to interpret and clinically use the test, we need to establish a threshold to divide patients with good outcome from patients with poor outcome. The problem is that achieving a perfect threshold is difficult. This is the largest study of NSE. The authors included more than 1,000 patients and assessed the ability of NSE measured on day 3 after cardiac arrest to predict neurological outcome measured using cerebral performance categories or CPC. CPC from 1 to 3 indicates recovery of consciousness with increasing degree of neurological disability, while CPC 4 and 5 indicate persistent vegetative state and death respectively. The scatter plot shows the distribution of NSE levels according to CPC. Now, if we put the threshold at 90 micrograms per liter, sensitivity will be 48%. In fact, about half of the patients with poor outcome are above that threshold. Positive predictive value will be 99%. In fact, there are 2 outliers with good neurological outcome above that threshold. We can consider increasing the positive predictive value further by increasing the threshold to 116 micrograms per liter. But in that case, we will decrease sensitivity without increasing the positive predictive value, which will still be 99%. And this is because there is an extreme outlier. If we zoom out, we can see that there is a patient with an NSE above 1200 and still having a good outcome. If we raise the threshold above 1200, we will achieve 100% positive predictive value, of course, but zero sensitivity. so our test will be completely useless. These outliers are common with biomarkers and are often due to a biomarker release from an extracerebral source, a neuroendocrine tumor in this case. But another very common cause with NSC is hemolysis. Outliers are the main reason why the thresholds for obtaining a 0% false positive rate with biomarkers are often very high and inconsistent across studies. This year we completed a systematic review on predictors of poor neurological outcome after cardiac arrest. And these are the thresholds for 0% false positive rate for NSC at 48 hours after cardiac arrest. They range from 34 to 120 across studies, but in most studies they were between 45 and 66. Now let's have a look at the study at the bottom, with 120 micrograms per liter threshold for 0% false positive rate and only 26.9 sensitivity. This result was due to outliers. Fortunately, the authors performed a sensitivity analysis in order to explore how the false positive rate in the first column and the sensitivity in the third column varied according to the threshold. The sensitivity analysis showed that if we lower our threshold and accept false positive rate values greater than 0, but still close to 0, for instance 1 or 2, sensitivity will be much higher. Please also note that these thresholds approximate the range between 45 and 66 we have seen in most of the other studies in the slide before. So, with predictors that are expressed as continuous variables, pursuing 0% false positive rate at all costs based on thresholds can be counterproductive. Instead, we can accept a minimum risk of false positive prediction and reinforce the signal by using a second predictor. This is indeed what we suggest in our guidelines for NSC and other predictors based on continuous variables or having inconsistent definitions or thresholds. These are classified as second-line or less robust predictors. They should be used only in combination. Now let's have a look at the most robust predictors. According to our current guidelines, these include SSEPs, somatosensory evoked potentials, and brainstem reflexes like pupillary and corneal reflexes. These predictors are dichotomous, and their false positive rate is virtually 0, but they have another problem, which is imperfect implementation and confounding. Pupillary light reflex, for instance, is a strong predictor of poor outcome after cardiac arrest. This reflex is generated in the mesencephalon, brainstem, and is not abolished by muscular relaxants or sedatives at therapeutical doses. It's very unlikely that a patient with an absent pupillary reflex at 72 hours from ROSC will have a good outcome, and this, in fact, is a strong predictor of poor neurological outcome included in our guidelines. However, false positive predictors have been observed with pupillary light reflex. For instance, in a recent multicenter study included in our systematic review, pupillary light reflex at 72 hours after cardiac arrest was scored as bilaterally absent in 5 patients who subsequently had a good neurological outcome. In that study, all patients were also evaluated with a pupillometer, which measures pupil size and reactivity quantitatively. And pupillometry showed that in all 5 patients with false positive results on conventional assessment, the pupils were instead normal reactive, but pupil size was significantly smaller than in other patients with poor outcome, probably as a result of residual sedation. In these patients, the change in pupil size was only a quarter of a millimeter, too small to be visible to the naked eye. I'm currently using only pupillometer to detect pupillary light reflex in my unit now. So, confounding and imperfect implementation prevent the most robust predictors to fully express their potential, and that's why our guidelines recommend that prognostication should be multimodal anyway, even in presence of one of the most robust predictors. Another important help for minimizing the risk of false positive prediction comes from predictors of good neurological outcome. These include an early continuous normal voltage EEG and reactive EEG, early high voltage somatosensory volt potentials, and normal MRI and others. The presence of these signs of good outcome is not compatible with the presence of robust signs of poor neurological outcome. For instance, these two recent studies show that when an early continuous normal voltage EEG was present, SSEPs were always normal. So if we have an abnormal SSEP indicating poor outcome in a patient with an early continuous normal voltage EEG, we can reasonably suspect that SSEP results are false. So in summary, most resuscitated patients die because treatment is withdrawn based on prediction of poor neurological outcome. False positive rate should be minimized when predicting poor neurological outcome after cardiac arrest. Unfortunately, no predictor is perfect. Even the most robust predictors do not predict poor outcome with absolute certainty. And that's why prognostication should always be multimodal. Also, be very cautious when there are discordant signals between predictors of good outcome and predictors of poor outcome. Thank you for your attention.